Welcome to the Pro Aging Podcast. I'm Steve Gurney, founder of the Positive Aging Sourcebook. We're excited that you can join us for our interactive discussions with pioneers and thought leaders on a wide variety of topics related to aging and longevity. Today we talk with Howard Gleckman, who's a senior fellow at the Urban Institute, where he's affiliated with the Tax Policy Center in the program on retirement policy. He's author of Caring for Our Parents and writes a weekly column on aging issues for Forbes. In 2016, Howard was named one of the nation's top 50 influencers in aging by Next Avenue. In our conversation, Howard talks about the key aging policy challenges facing the Biden administration and shares his unique and informed perspective on our future. This talk features more questions and comments from the audience than we've ever had. So let's jump into our conversation with Howard Gleckman. So Howard, welcome. And the interesting thing is, the last time I had you as a presenter for one of my events, it was a live event at, I believe, the Washington Hebrew Congregation. And you were talking about aging policy in the Trump administration. Isn't that right?
That's right. That's right, Steve. It seems like it's so long ago, right?
Yeah. It really was. It was right after he got elected, and I saw an article that you wrote for Forbes, and I was like, ooh, I wonder if Howard will come. And that was an interesting presentation, and it would be great if you could reflect on some of the things that you maybe shared with us at that event. But before we do that, I know a lot of our audience members know who you are, but let's get to know you a little bit better. And actually, as we do this, I hope I'm not embarrassing you when I bring this up, but I'd like to kind of take a step back and reflect on how I met you. And I believe you've been a journalist your whole career, but you can share that with everybody. But you were at a point where you were questioning your career, and you reached out to me and some others in looking into becoming an aging life care manager. I know back then it was a geriatric care manager. Am I correct in that? That's how our paths first crossed?
Yeah. So, Steve, that's almost 20 years ago. I hate to bring it up, but yeah. So I, as Steve said, I was a journalist for much of my career. I worked for the last job I had was at Business Week, where I was a senior correspondent in their Washington bureau, and I covered healthcare issues and economic policy issues. And I found myself a caregiver. My mother-in-law and father-in-law lived in Florida. My mother-in-law died suddenly. My father-in-law could not take care of himself. We brought him up here. And just shortly after we did that, my dad got sick, and we had to arrange care for him. And I found myself in the middle of a world that I didn't know anything about. I was, like so many family caregivers, utterly overwhelmed by what I was facing. And I got really interested in it. I got to ask lots of people questions about what was going on, including Steve. Learned a lot about it, and then decided to actually make a transition out of journalism. It didn't quite go the way I started exploring. I went to work for an organization called the Urban Institute, which is a think tank in downtown DC, where I do policy research in aging issues. And I've also had an opportunity to continue with sort of semi-journalism. I write a regular weekly column for Forbes.com on aging policy issues. And then in my free time, I've done a lot of volunteer work. And currently I'm the president or the board chair at the Jewish Council for the Aging in Rockville. I also serve on a couple of boards for Johns Hopkins Medicine. I've been the president of chair of the board of Suburban Hospital. So really had a chance to get involved in this set of issues, both at the policy level and kind of at the 30,000 foot policy level, and then at the really on the ground level with my JCA work and my hospital work. So it's been really interesting.
Great. Well, Fantastic. Well, we're thrilled to have you and thrilled to gain some of your insights on what what might happen here with this new administration in office. And so, what I want to, I guess, if you want to just jump in and start sharing your thoughts, and what I'd like to remind the audience of is that um, as a question or a comment comes to you, just type it in Q&A and we'll make sure to address it. Okay. And then after Howard shares some of his thoughts, we can have, an interactive discussion with Howard and all of us. So Howard, I'll let you kind of take it down whatever path you want to go with what's going on in aging policy in the new administration.
Okay, Steve, thanks a lot. And what I thought I'd do is I'd start by level setting a little bit, talking a little bit about the circumstances we're in now. And much of this will be familiar to some of you, but I think it's worth sort of talking about. When policymakers think about what they're going to do, they think about what's the problem we're trying to address. And of course, the immediate problem they're all trying to address is the pandemic. And as you all know, it's been just brutal for older adults, for people in senior services. This has just been an extraordinary year. Since the pandemic began almost exactly a year ago, 150,000 residents and staff of long-term care facilities have died of COVID-19. Roughly as many older adults living at home have died from COVID. That's a statistic that most people are not familiar with, but it's true. And that doesn't include the people who have died from social isolation related to COVID. There's very little data on this, but I've heard so many anecdotes about people who have been suffering from social isolation, failing much more quickly than they were expected to, especially those with dementia, but others as well. People who just, they haven't seen their family members now in almost a year, and the effects on their psychology, on their mental health, have been just really, really hard. The pandemic has also created tremendous distress for state budgets. And that's very important as we think about Medicaid. Fewer revenues, of course, because so many people have lost their jobs. So state budgets are in trouble there. And because so many people have lost their jobs, many more people are going on to Medicaid. These are working age people and their families who are putting a lot of pressure on Medicaid. And as I think you all know, the way Medicaid is funded is about half of the money comes from the states and about half of the money comes from the federal government. This pressure on Medicaid funding has certainly gone to affect Medicaid long-term services and supports. And those programs are certainly facing no increases. And many of them, I'm afraid, are going to face cuts without federal assistance. The other set of consequences from the pandemic, of course, are how they've affected senior housing, senior service organizations. In January, the occupancy rate for assisted living was 70%. That's down 10% from pre-pandemic levels, and it's the lowest occupancy in 15 years. Some facilities have seen a little bit of a bounce back, but nationwide, the outcome remains pretty grim. It's worse for nursing homes. The occupancy rate is down from an average of 90% to 75% nationwide. And the cutoff for success for most facilities is about 80%. The trade association for the for-profit nursing home business, the American Healthcare Association, estimates that operators lost $11 billion in 2020, and those losses are projected to rise to $22 billion in 2021. There have already been about 143 closures and mergers in 2020, and the industry expects that number is going to increase to almost 2,000 through 2021 if business conditions don't change. Overall, for senior living, occupancy rates are about 80%, which is right on the borderline of success or failure. The DC area has actually had fewer declines than other markets, but it's still substantial. Of course, the good news is vaccinations. We're starting to see vaccinations now in most nursing homes and now increasingly in assisted living facilities. And with those vaccinations, we're actually beginning to see that deaths and cases of COVID are declining. For the world of home care, of course, demand has been very strong, but there's been a big constraint, which is the supply of aids and the rise of labor costs. And then finally, there's the effect on families, and it's been just terrible. Uh, Many family members, of course, lost their own jobs, and that meant that they had to either take family members out of long-term care facilities or cut back on home care aids because they just couldn't afford it anymore. Respite care, such as adult day and senior centers, have been closed now for more than 10 months. Um, so, facing all of that, the question is, what are policymakers going to do about it? The first thing I want to talk about actually is less a federal issue than a state and local issue. And that's the question about what are we going to do about getting vaccines to homebound seniors? Uh, we've done a very good job actually getting them to people in nursing homes. More needs to be done, certainly, particularly in assisted living and independent living, but we're getting there. When it comes to homebound seniors, most jurisdictions have done absolutely nothing. I don't think they've even begun to think about those folks who are living at home and can't get to a facility. And of course, to say nothing of what it's like to try to make an appointment. I certainly have been trying to do that myself, and to say it's a challenge is a sort of the understatement of the week. Let's talk about what some of the policymakers are going to do on the federal level, and let's start with Medicaid home and community-based services, which I think are going to be the biggest priority in terms of the initial policy making we're going to get from the Biden administration and from Democrats in Congress. In his presidential campaign, President Biden proposed spending more than $450 billion over 10 years to enhance Medicaid HCBS. And mostly his goal is to eliminate state waiting lists. That's a big deal, for example, for Maryland, because it has one of the worst waiting lists in the country. Congressional Democrats are picking up on this idea. In the new stimulus bill, which they're debating now, the House is considering a 7.3% increase in the federal contribution to Medicaid HCBS for 1 year only. Again, that's a contribution not to all of Medicaid, but just to Medicaid home and community-based services for older adults and people with disabilities. States would have to use the money for at least one of the following programs. And there's a very long list, but I'll just give you a few of them to give you an idea of what the money would be available for. It could be used to increase pay for home care workers, for PACE programs, and for other programs that support home and community-based services. It could be used to provide paid leave or hazard pay to home health workers. It could be used to purchase emergency supplies such as PPE or home health for home health workers or for family caregivers. Assistive technologies could be funded, training for home health workers. It could be used to fund programs to assist nursing home residents to return to home. So there's a whole long range of issues. This is, again, just being debated in the House. It's got a long way to go. Most of the talk is that they're trying to get a bill finished by the middle of March, so about a month from now, but it's certainly something worth keeping an eye on. Another provision in the House bill, which is still being drafted, would provide about $250 million to deploy what they call state strike teams to nursing homes that are suffering from outbreaks of the COVID infection. Again, I don't know if that's going to make it into the final bill, but it is a significant chunk of money that could help facilities that are still having problems. I should say that the trade associations for the nursing home industry have been lobbying very hard to get additional funding directly to them. They got, during the last year, they've gotten a couple of $100 billion in assistance. Frankly, I think it's very unlikely they're going to get any more from President Biden or from congressional Democrats. Some of the other ideas that Biden has proposed that are not going to be necessarily in this first bill, but are something to watch over the course of the next 6 months or so. First one is paid family leave, and that would include families caring for frail older adults and relatives with disabilities. There have been a number of family leave bills kicking around Congress for the last several years. Nearly all of those have been focused on parents of infants or adopted children. They've largely ignored the needs of families caring for older adults or people with disabilities. I think that this next round of family leave legislation is probably going to include those caring for older adults. It's a huge benefit for people. Certainly doesn't solve everybody's problems. 12 weeks of family leave, if you're caring for a parent with dementia, is not certainly going to change your life completely, but it's still a big deal. It's still going to matter. Um, Another issue that's certainly on the table is the $15 minimum wage. That's something that, of course, many home care workers would love to have. For home care agencies and facilities, it's going to mean an increase in labor costs. And the question is, how's that going to get paid for if there's not more money in Medicaid or more money from people who are private pay residents or clients? One other issue to watch legislatively is there's some proposals out there for tax credits for family caregivers. There's a very small program now that provides a tax credit for dependents, but it really doesn't work very well for people who are caring for parents. Works much better, again, for people who are caring for kids. There may be an expansion of that program. It may be a little more generous and maybe a little more flexible. We'll see. Another place to look for change is actually regulatory reform from CMS, from the federal government. The first thing that has to happen there is the president has to pick an administrator. Right now, the agency is running with an acting administrator, who's Elizabeth Richter, who's a career CMS employee. Elizabeth's very good, but she's not the political appointee that they need. This is going to be especially important because the new nominated secretary of HHS, who's a former congressman and California Attorney General, Javier Becerra, has good political connections, but he's got no healthcare background, except that his wife is a doctor. Unfortunately for us, she's a pediatrician, not somebody who knows about elder care. It's going to be very important for him to pick somebody. A lot of the policy will be driven by who he chooses. Some of the areas where I think you're going to see HCBS enhanced in terms of federal regulation is one area is going to be simplifying waivers for states. So what happens now is there are about a half a dozen different waiver programs that states have to go through in order to get more home and community-based services. It's a very complex process. It takes a long time. One of the problems is because there's so much turnover in state Medicaid programs is you get a Medicaid official who's very interested in doing an expansion of HCBS. He goes through all the paperwork, and then by the time the paperwork is completed, that person's left, and the next person may be less interested. So it's a real challenge, and there's a lot of interest at Medicaid, even before the administration's changed, in making this waiver program simpler. Another area to watch out for is nursing home regulation. Many of the regulations were waived during the pandemic. They're allowed to use something called a health emergency to waive regulations. Some of them involve staffing at nursing homes. Some of them involved oversight of nursing homes. Those waivers had consumers very unhappy. But the providers, of course, were pleased to avoid some of the paperwork at the worst of the time when the pandemic was so difficult in the facilities. There are two other sets of temporary changes to regulations that are very important both to providers and to families. One of them is that the so-called 3-day rule was waived. The 3-day rule is the rule that said that if someone has not had a 3-day stay in an acute care hospital, when they are discharged, any post-acute care that they need is not paid for by Medicare. It has to be paid for by the family. That rule drove people crazy. You had all sorts of efforts on the part of hospitals and other people to game the system. Hospitals hated the rule too, even though they were often blamed for imposing it. That rule has now been waived temporarily. And there's a lot of interest in making that waiver permanent. It's going to cost money because it's going to mean that Medicare is going to pay for a lot more post-acute care than it has paid for. But it's got I think it's generated a lot of interest, and it's going to be interesting to watch. Another temporary set of rules involves telemedicine. Telemedicine is of course, was growing even before COVID. The problem with it was Medicare wasn't really paying for it. There's now temporary regulations that allow Medicare to pay for telemed, and it's going to be interesting to see whether those rules are made permanent as well, or whether Congress, in fact, is willing to change the law so that telemed becomes more flexible and more commonly used. Very important for older adults who may find it very difficult to actually get to the doctor. Uh, in terms of the nursing home rules, there's going to be a real balance here between safety and maintaining the social connections that people need. One of the things that worries me a lot is politicians being politicians will respond to the COVID crisis by imposing very strict infection control rules on facilities. And at first glance, to consumers, that may sound like a great idea. Why would you want to have, anything other than strict infection control rules? The problem is that you can imagine those rules that would make it really unpleasant to live in a facility. It's what people are living with now: limiting visitors, limiting access to the dining room, limiting access to day rooms. You don't want a set of regulations that essentially are going to say that nursing home residents are trapped in their rooms, and the only people they're going to ever see are staff people who are showing up in moon suits. That's not a way to live. So it's going to be a real challenge to find a balance between strong regulations that assure good quality infection control, but not to go overboard so that people are living in just an awful kind of situation. So we'll see how that goes. Some of the areas I'm sure that they're going to do is much more stringent requirements about hand washing and wearing gloves and that sort of thing. Real question is what's going to happen to double and quad rooms, which still exist in a lot of facilities, particularly for Medicaid residents. I have a feeling that those are going to be gone. I think a lot of those rooms are history. They're not going to happen anymore. Another area to look at is managed care. There's been a real growth in recent years in Medicare Advantage plans offering social supports and non-medical benefits that may include things like nutrition programs or transportation programs. This program just began about 2 years ago, and now about 900 Medicare Advantage plans are beginning to offer these services. They're quite limited right now. Maybe they're worth $30 or $40 a month, but I think we're going to see more of it, and you may see more flexibility from Congress in terms of allowing plans to offer these programs. Last thing I want to talk about for just a few minutes is long-term care financing. Much of what I've just been talking about is going to cost money. Some of it will be funded by Medicaid, but the question is, what about private pay? As most of you know, I think private long-term care insurance, particularly standalone long-term care insurance, has almost disappeared as a product. Last year, 54,000 standalone policies were sold in the entire country. So people are looking for other alternatives. And one possibility is the idea of a public long-term care insurance program. Washington State passed a program in 2019. It's what they call front-end benefits. So the state would pay the first $36,000 a year for the first year, essentially $100 a day for the first year. After that, you'd be on your own. This would be funded by a payroll tax. I've worked with some other people to suggest a different idea, which is a catastrophic public program. And the idea is you would be responsible for the first period of time, and you could fund that care out of savings or home equity or a short-term private long-term care insurance policy. But then if you had a true catastrophic need, the government would pick up that cost after a period of a couple of years, say. There was a bill introduced by Frank Pallone, the chairman of the House Energy and Commerce Committee, a couple of years ago. It didn't go anywhere, but now there's some more interest in it. A congressman named Tom Suozzi from New York is about to introduce a similar bill. So I think we're seeing a little bit of interest on that at the federal level. There's also a lot of interest in this idea of a public long-term care insurance program at state levels. So Washington State's done it. California, Minnesota, Illinois, Michigan are all considering the idea of public plans. They're all in a relatively early stage, but it's something to watch. It's also important to know that President Biden did not endorse this. Some of us talked to his staff people. about whether or not he would include such a proposal in his campaign platform. He didn't in the end. It's interesting, the Transportation Secretary Pete Buttigieg, when he was a candidate, did include this public program. So there's at least one person in the Biden administration who's aware of this and interested in it, but he is the Secretary of Transportation. He's not the Secretary of Health and Human Services. So I'm not sure how far it's going to get. Uh, the, the big issue, though, is how are we going to pay for all this? How are we going to pay for long-term care? How are we going to pay for the ancillary services that people who are getting home care need? The Older Americans Act has been underfunded for years. We'll see if it gets more funding now. So as usual, the question is not the desire to look for reforms. The question is, how are we going to pay for them? So let me stop there, and I'm happy to take questions for a while. This is a great opportunity to hear from you.
Man, well, thanks for those insights. And it's interesting. I completely forgot about what you were predicting and what you were sharing with us when Trump came into office. But the fact that we have basically run into this brick wall called COVID-19 makes a lot of it irrelevant no matter what. The We do have some questions, and I would encourage folks that if you've got a question, either type it in. You can raise your hand if you prefer to verbally ask your question as opposed to typing it. But let me kind of jump into this. And first on the list is Joe Sperling, who says, do you see any movement toward government provided long-term care insurance, or do we anticipate a continuation of requiring private purchase of this coverage?
Well, as I said, I think that there's a lot of interest in the idea of some sort of either a state program or a federal program that would supplement private long-term care insurance. I think policymakers still are looking for ways to support a private long-term care insurance market, but it's increasingly difficult. There are very few companies that are now selling long-term care insurance, because the risk is just so great. What they call the tail risk, the risk of people with very long spells of long-term care, are making it financially almost impossible for a long-term care insurance company to make money. And of course, what we're seeing are these enormous rate increases. I got a call the other day from somebody who told me they got a notice from their company telling them that the company would be asking for a 300% increase in long-term care insurance premiums over the next 5 years, and asking them whether or not they wanted to keep the policy or not. So it's a tough environment for the insurance companies. It's a tough environment for people who have policies and are trying to continue to pay these ever-rising premiums. So the idea of a government-provided insurance policy to supplement long-term care is an idea that's got a lot of interest. The problem is how you're going to pay for it. It would require some sort of a tax increase, and nobody wants to do that.
Yeah, I tell you, I mean, and with all the money that we've been spending to get through this pandemic, it's the competition for government dollars is huge, So
yeah, Steve, if we're going to do it, if we were going to do a public program, it would have to be self-financing. The idea of another, underfunded entitlement program just isn't going to happen. So the tax, or if you want to call it the premium, for this public program would have to be sufficient to pay for the benefits. We calculated when we put together a proposal to do this a couple of years ago. We calculated that if you raised payroll taxes by 0.5%, which means for a median income family or median income worker about $300 or $400 a year, that would be sufficient to pay for a program like this. But are people willing to support a payroll tax increase? Good question.
Great. Let's see. This is a good one from Wendy Zenker. Any insight about support for nonprofits providing support for older adults to stay in their homes and communities as they age, i.e. the villages? Wendy is with Arlington Villages. Thoughts on that, Howard?
So the villages are interesting, and I'm conflicted about the idea of public support for villages, and here's why. I actually love villages. I think they're a great model. Um, but one of the things I love about them is that they're so grassroots and they operate kind of in their own way. And a village in one community may be quite different from a village in another community. If villages are going to get public money, that public money is going to come with strings. And it's going to come with all sorts of rules and regulations about what you can and cannot do. And I think to some degree that damages the whole point of the villages. So I can understand why people in villages would like to have a little support, but I worry about what the cost of that support would be.
Yeah, it's reminiscent of what happened to nursing homes with government support. Strings are attached, and yep. Mark Ash says, "How can we get our legislators to a place where they recognize that keeping people healthy with wellness programs and preventive support would be far better health model and far cheaper?"
You're absolutely right. It would be. Um, it's very hard to get people interested in preventing a problem. They're much more interested in fixing a problem after it happens. COVID actually is a classic example of that, right? I mean, the idea that there was going to be another pandemic was hardly a surprise to anybody. You know, people remember we had a couple of near misses with SARS and with bird flu and some of those others. It was going to happen. It's going to happen again. It isn't a surprise to people who know nursing homes. I mean, we have outbreaks of viral infections from seasonal flu every year in nursing homes. So this was going to happen, and nobody did anything about it. And it's the same thing with preventive care. People just don't think about it, and frankly, the preventive care lobby is much less effective than the world of the subspecialists and the very expensive specialty hospitals and all the rest of it, who take care of you after you get sick.
Yeah, it is one of these things. I always say that if you want to bring community together, and I started a village in Reston, Virginia, and I tried to get our community together to support the older adults that need help. And it's hard to do that, but you want to get community together, redraw the school boundaries. You will jam pack a gym full of folks, and you're right. I mean, that is one of the benefits of COVID is we have come together and we've reacted, and we're utilizing technology in senior living like we've never done before. It would have taken years to get to the point where we're at right now. So let me keep on going because there's lots of questions here. Lots of thank yous for your presentation, but this attendee was wondering, are you caring for anybody now? He really liked how you shared your story. Are you currently a caregiver in the field?
No, I'm not. Both my in-laws and my parents have passed away, so I'm not caring for
Okay.
anybody now.
Jennifer Brown says, given the occupancy rates, do you see assisted living and or nursing home operators declaring bankruptcy or closing?
Yeah. I know Bob Kramer is one of our attendees today, and Bob knows way more about this than I do. But yeah, I think we're going to see a huge shakeout in the nursing home, particularly the nursing home business. Um, this is kind of another whole conversation, but the traditional pre-COVID business model of nursing homes, I think, has been so disrupted that it's hard to see how it's going to come back. And to just briefly describe it, the situation is that most of long-stay residents of nursing homes are Medicaid recipients. The Medicaid bed rate payment is insufficient to even pay the costs of the care. So what most nursing homes do is they use their post-acute care to cross-subsidize, and then Medicare pays them quite well for providing post-acute care. The problem is that a lot of that post-acute care collapsed because of COVID. Much of it was rehab from hip replacements and knee replacements, and those surgeries just ended. and the rehab is not coming back to the nursing homes. It's going to come back some, but not like it was. A lot of that rehab is going to happen at home now. I think one of the things people learned from COVID was you could do this at home. More managed care is interested in doing this at home rather than a nursing home where it's less expensive for them. So I think without a lot more Medicaid money and without additional revenues from Medicare, it's going to be very difficult for nursing homes to sustain the business model that they have had. So they're going to have to be very creative to figure out what it is they're going to do. The other thing, one last point about this, is I've calculated that probably 20% of the Medicaid residents of nursing homes have no clinical reason to be in the nursing home. They're only there because that's where Medicaid pays. And if there were a more robust home and community-based system, those people would be living at home rather than in a nursing home, which doesn't, I mean, nursing home is just not an appropriate place for them. So I think there's going to be a lot of changes, a lot of disruption in the nursing home business, and to some degree in assisted living as well.
Yeah, great insights. Now, to sort of counter that, one thing that I've been hearing from a lot of our readers is that an awareness of how exhausting it is to be an in-home caregiver. Um, several several folks that I've talked to, when this hit, pulled mom and dad out of a nursing home to care for them at home, and quickly discovered that, geez, it wasn't that bad. And so I think, but as you had said, you'd mentioned creativity. I'm blown away at the creativity that our field has uh, shown in this pandemic, and I'm excited to see the creativity that they enlist moving forward here. This is a good question. What are your thoughts on potential policy changes regarding adults and mental health priorities, which are, spanning all ages here?
Yeah, this is a huge issue, and of course, this was getting a lot of traction even before COVID. Tremendous focus on behavioral health and our inability to manage that. I mentioned that I was the board chair at Suburban Hospital. Suburban was inundated with behavioral health patients. Even in Bethesda, Maryland, where you don't think about this, it was a terrible problem, and even before COVID. I mentioned before the cost of social isolation, and again, we have no data yet, but anecdotally, the levels of depression from older adults who have been isolated from their families and their friends is just increasing dramatically. And we need to begin to think about how we're going to confront this. It's particularly a problem for older adults. I'll say, I don't know if there are any physicians on here, and I hope I don't offend anybody, but one of the problems that older adults have is you go to your physician and you say, Doc, I'm a little depressed. And too many physicians say, well, you're old, your friends are all dying. Of course you're depressed. Don't worry about it. Here's a pill. And we need to think a lot harder about mental health for older people and how we're going to help them manage it. Was, as I said, a big priority before COVID. It's a giant priority now. And we really need to work a lot harder to make sure that it gets addressed.
Great. Man, tons of questions. This is awesome, guys. Howard, I hope you buckle up here. We've got a bunch more.
I got time.
EJ Burrows says, telemeds question, like housing costs is based on location. Why aren't the meds the same? Seniors can't afford a lot of meds, and they may need to take, so they must decide amongst rent, food, or meds. I know this is an issue that has been plaguing us for many years.
So this was an interesting one, right? Because this is one where President Trump seemed to be as interested in dealing with the high cost of pharmaceuticals as the Democrats. Never quite got anywhere with it. He came up with this crazy plan at the end. He was going to give everybody a $200 gift card, which never happened. That's not the solution. But I think there is bipartisan interest in Congress in addressing the question of pharmaceutical costs. the one of the political challenges, of course, is these are the same politicians who are going to pharmaceutical companies and saying, we need you to get us COVID vaccines faster. So there's a little bit of a disconnect there. And I think that the pharmaceutical companies are going to come out of this with a little bit of leverage that they didn't have before. And it's going to make the politics of this a little complicated. On the other hand, I think there's a recognition that Americans are just paying too much for many drugs. And it's happening at different levels. Everybody remembers the stories about, some of these routine drugs where suddenly the prices were going through the roof. And then at the other side, the other end of it, you have, what do you do about these highly sophisticated new cutting edge drugs, cancer drugs, for example? I have a friend who recently was getting a course of treatment for one of these immunotherapy drugs. And, he asked he was in a trial, and he asked the docs running the trial what this drug was going to cost. And they said $300,000 a year. That's the reality. What do you do with that? So I think there's going to be a lot of talk about it. I'm confident that probably over the next year, we're going to come up with some sort of a solution. I can't really tell you what it's going to look like yet.
Yeah. And I remember that is one of the things, one of your hopeful insights on when you talked about when Trump came into office was that he was going to be able to get the pharmaceuticals to the bargaining table and somehow adjust the pricing of pharmaceuticals. Let's see, Maritza asks, what's the likelihood that the Family Leave Act will include elder care? It's been a challenge for many adult children caring for older adults. Why is this consideration taken so long?
Yeah, I think that it is a very good chance that a family leave bill will pass Congress, and that family leave bill will include, make it possible for people who are caring for older adults to use that leave. I think that's as close to a done deal as possible.
Yeah. And well, one thing for sure, the culture now of working from home makes it easier to have a loved one that you're caring with and still maintain your job. Heidi Garvis says, how will Medicare Advantage plans include home care, and will home care agencies react? I've heard that agencies cannot survive based on the ROI.
Yeah, this is a rapidly evolving environment. And we're just going to have to see how it goes. Everybody's experimenting here. The plans are trying to figure this out, and the home care agencies are trying to figure it out. And nobody quite knows where it's going to go. I think that there's going to be an element of home care provided through Medicare Advantage plans. The payment rates from the plans to the home care agencies are going to have to be negotiated, just like the plans are negotiating with nursing homes and everybody, and doctors and everybody else. So the challenge for the home care agencies is, the MA plan will send me business, but in return for that business, they're going to want a lower rate than what I normally charge. And this is all happening, of course, at the time when labor rates are going up. So how do I make all that work? It's going to be a matter of negotiations among everybody. It's going to be particularly interesting when you look around here, because Maryland has relatively little managed care in Medicare. A couple of small plans in this area, but not much. Virginia's got much more. So Virginia, I think, is going to be sort of ahead of the curve here, and we'll get to see how this goes in Virginia, and then we'll see where I live in Maryland whether they adopt it.
Yeah. Let's see. Joe Sperling is more of a follow-up comment. He's just asking, are you aware of the new hybrid life long-term care insurance plans? And I think this speaks to innovation, the fact that a traditional long-term care insurance plan is cost prohibitive, and the people that can afford it don't really need it. They can self-insure. The companies are creating these hybrid plans.
Right. So they call them hybrids, or sometimes they call them combo products. And essentially what they do is they combine a whole life insurance policy or an annuity with a long-term care insurance benefit.
Uh,
And they've done very well. They sold about 300,000 policies last year. The problem with them is that the market is relatively limited. To get a benefit that's really useful for somebody, you've got to buy an annuity that's worth several $100,000. And you think about the middle market, you think about middle income people, they don't have $300,000 to put into an annuity. Um, it's a interesting product for a slice of the public, but when you look at it through my lens, which is what's a way to get long-term care insurance to middle class Americans, I'm just not sure it's going to work.
Paul Nasta says, since people are living and working longer, some not retiring until they're in their mid to late 70s, do you anticipate an increase in the age qualification for Medicare or Social Security?
Well, of course, Social Security retirement age or Social Security full benefit age has been increasing gradually for a couple of decades now. Uh, Medicare, I think, is actually more likely to go in the other direction. There's been a lot of talk from President Biden during the campaign and from other Democrats about actually allowing a Medicare buy-in for people 55 and older. And it's an interesting idea because people 55 to 65 tend to have relatively low healthcare costs. And if you kind of put them into the pool with Medicare people, you actually may be reducing the overall Medicare cost. But I think they need to figure out where they're going to go here. You know, you got the Democrats who want to do a public option. You got Democrats who want to do the full-blown Bernie care. They're going to have to figure out where they're going to go here. This is a priority for Biden, but I think it's a secondary priority to getting us through COVID. So we'll probably hear more about this maybe at the end of this year, but not for a while.
EJ Burrows asks, have you ever heard anything about legislation or for rent control on senior housing?
No. What I have heard about, though, is a lot more discussion about what we can do with low-income senior housing. There's not nearly enough of it. And this is mostly funded through a program called the 202 program at HUD, and it's been underfunded for years. So I think there's more interest in the Biden administration in spending money on subsidized housing for low-income people, low-income older adults. And then the other really interesting issue about that is, can we also provide services to people living in low-income senior housing? There's some really interesting experiments around the country, one in Vermont, where you can use waiver programs, states can use waiver programs to actually provide a wellness nurse, for example, going back to the question we had about wellness care. You can get a wellness nurse who can actually be located in a senior living, low-income senior living facility and do wellness checkups. You can have a social worker who can help people get that. And the evidence is these programs work really well. They avoid hospitalizations, they avoid emergency department visits, the people are happier, but you need to figure out how you're going to pay for it. It's the usual question, but they're great ideas.
Yeah. Let's see. Gene is asking a question about raising the base pay for personal and home caregivers. And I know you mentioned the minimum wage, but has there been anything out there to offer subsidies or offer this group of professionals more of a living wage? And shoot, one of the things that I've been involved in conversations for years is the fact that many of these people that are caring for us don't have health care for themselves. So when they throw their back out caring for your mom and dad, they don't have any place to go.
One of the great scandals of the way we treat older adults in this country is that vet techs are paid more than home health aides. Yeah. And what that says is this society values the people who care for their cats more than the people who care for their mothers. And you know, that's just outrageous. So I think there are a couple of things that are going on here. One of them is, of course, labor rates are going up. COVID has made it impossible to hire people at the wage rates, the pre-COVID wage rates. the Trump administration immigration policy was already creating problems with labor supply, and now it's much worse. So that staff is being paid more. Now, some of that we'll see whether that's temporary, and if and when COVID goes away, whether those wage rates decline again. But for now, I think wages have gone up some. But in most markets, the home health wage is set by Medicaid. That's the driver, and goes back to what I was saying at the beginning. Medicaid is just insufficient. This new bill is going to provide temporary additional money to pay higher wages, but only for a year. And then what happens after that? There also have to, it's more than money. I think the aides, they need respect. They need opportunities to advance in their careers. They need benefits. They need sick leave. They need pensions, or at least the opportunity to participate in a 401k plan. They need all of that. And of course, for the agencies, that they got to get money to do that.
Great. Good thoughts. Okay. You mentioned that Maryland has the longest Medicaid waiver waiting list. Could you elaborate on why and what can be done as a home?
So I don't know if it's the longest, but it's certainly among the longest. Okay. So why? The answer is pretty simple. Maryland is not funding its Medicaid home and community-based programs sufficiently. It's a sort of an obvious answer, right? But if there were more money in the program, the waiting list would be shorter. And Maryland, if you look at it on paper, has a wonderful program, but the way it does it on the cheap is it makes it hard to get in. So what could be done about it? Everybody needs to go to Annapolis and lobby the state to spend more money on Medicaid home and community-based care. The other thing that Maryland and other states do, which is just awful, is they have different waiting lists for different Medicaid HCBS populations. So the traumatic brain injury people have their waiting list, and the older adults have their waiting list. And the DD people, the developmental disabilities people, have their waiting list. And this is a very cynical effort on the part of states to pit the different interest groups against one another. The effective lobbying would be if they all got together and fought for more Medicaid money. But instead, what happens is they fight each other for a slice of the pie. And as I say, it's a very cynical exercise, but Maryland's been getting away with it for years.
Man. And it's almost 1:00. We still have a pile of questions. Are you okay going on for a few more minutes, Howard?
Sure. Absolutely.
Okay, great.
I just have to have lunch at some point. That's all.
Yeah. We'll get through this. And for those of you that might have to jump off, we're going to be recording this. I'm also going to have this as a podcast, so you can listen to it while you're walking your dog. Maritza says greenhouses have had a much lower infection rate than other nursing homes. Why has this model not been promoted, considering the benefits?
So greenhouses are an interesting story. The evidence seems to be that yes, they have had lower infection rates and fewer deaths. In many cases, actually no deaths. One of the interesting questions is why, and we've got to pick apart whether it's because they're small, because as I think people know, greenhouses are generally 10 to 12 residents, or whether it's because of the way their staffs operate. And we don't know the answer to that. We got to pull that apart. But there seems to be no question that for some reason, greenhouses are doing much better. One of the interesting questions about greenhouses, which I've had I've been writing about these things for 15 years. And one of the things that's so interesting about them is they haven't replicated as much as people thought they would. It seems to be not easy to make money in the greenhouse business. And some of it is for the same reason it's hard to do it in any nursing home type business, because the Medicaid rate, I keep saying the same thing over and over again, the Medicaid rate is so low. But they're terrific models. I've been to a number of them. And a lot of people are replicating them, maybe not necessarily as greenhouses, but as greenhouse-like projects.
Small houses, right? Small houses, yeah.
Exactly. But they're not catching on as much as I would have hoped they would, and I don't really understand why not.
Agreed. And I think the broader thing, I like how you frame that, because the not just greenhouses and small house nursing homes, but also like smaller assisted livings, sort of like the neighborhood model is that the the value of having less residents for the caregivers to care for. You can keep an eye on them. You can isolate them if somebody gets infected much easier than a larger um, model. However, same way that we run our schools, how do you manage a large amount of people most effectively, in larger buildings, in larger classrooms, and what have you. Um, let's see. Uh, area state agencies on aging, area agencies on aging, area service access points. These are all very complicated and confusing. Um, any thoughts on how we can make these government entities more efficient?
Yeah, I mean, this is a source of great frustration. I will tell you, for me, uh, it, it is so difficult for a family member who's caring for a loved one at home to navigate this system. It is so complicated. Where do I go for transportation? Where do I go for nutrition? Where do I go to find a doctor? Where do I find adult day programs? Where's this? Every one of these things is different. In theory, the AAAs or the ADRCs were supposed to be the one-stop shop where you could get all this information. The reality is that the quality of these programs varies from state to state and from county to county. Some of them are terrific. Some of them, frankly, are terrible. And until we get some kind of consistency and some less complicated system of doing this, it just isn't working for people. One of the things that I hear from the AAAs all the time is, seen one AAA, seen one AAA, and they're kind of proud of the fact that they're so different. Well, yeah, but we ought to have some kind of quality standards, and you ought to be able to get at least a minimum amount of information from any of them. And sadly, that's not always true.
Mm-hmm. Let's see, Catherine McCallum, who was an executive director of a village, completely
Yes.
agrees with you, but she's wondering, do you have some ideas on how these grassroots organizations could partner to make the world a better place?
So, hi, Catherine. Catherine's an old friend. So, I think that there's one thing that I think that they can do is they can avoid reinventing the wheel. So, just a shameless plug. I mentioned that I'm the president of Jewish Council for the Aging. We coordinate a lot of the transportation for the villages in Maryland. And it seems like that's an interesting model. There's no reason why every single village should have its own transportation coordinator. You could actually do this kind of collectively, and it can actually run fairly efficiently. The villages tend to be very jealous of what they do, and they don't like to play well with others. And I kind of understand that, but I think there are opportunities for them to collaborate more. I think it's important to recognize that this area probably has more villages per capita than any other part of the United States. It's really caught on here, but there are still gaps here as well. And one of the big gaps is a racial and economic gap. Villages in this area and villages really around the country do very well in well-educated, higher income, mostly white communities. And it would be nice if we could figure out a way to do a better job engaging lower income people of color in these kinds of villages. I've thought for a long time that maybe you could do this, maybe not basing it so much on neighborhood, but maybe you could base it on a faith community, base it on a church. Uh, I think there are other models to think about. I know Capitol Hill Village tried very hard to integrate into its very complicated ethnic community of Capitol Hill, and it was a real struggle for a long time. So I think we need to do a better job here with making these villages more than just something for upper income white communities.
Great. And actually, Retta Vincent is on, and I see that she is thanking you for the shout out on the Village Ride program there. Okay, I love that Louis Tenenbaum is on this call. because he has a question that I'd love to hear your feedback on. How do you see the role of home modifications in enabling folks to remain in their homes longer? And then he's sort of asking, what could there be, tax incentives similar to the way that they've got tax incentives for solar and hybrid industries for modifying your home to make it more safe and accessible?
Interesting idea. I hadn't really thought about the idea of tax incentives to do that. In terms of the role, I think and I'm not surprised Lewis is asking the question, right? But I think it plays a very important role. I think we have come to realize that with relatively modest home modifications, you can keep people at home. Medicaid, I think, needs to be more flexible in terms of its funding of these programs. Private long-term care insurance needs to be more flexible in terms of its funding for these programs. But I think it's a very important piece. There's a program out there called Capable, which is a really interesting model for Medicaid recipients, and Capable provides a handyman and a social worker and a occupational therapist. They go into people's homes, they ask them what they need to stay at home, and they put together a plan to do it. And for very little cost, they can do a number of steps, including some minor home modifications, which really make it possible for people to stay at home. And these have been very carefully studied, and the outcomes are very powerful in terms of satisfaction of the participants, and fewer hospital visits, fewer emergency department visits. It really works.
Great. I see that that's run through NCOA. I'll look into that, and maybe we'll have the Capable program on at another discussion.
That'd be a great idea.
Let's see. Allison Donardi is would love to hear your thoughts on, with COVID, outside providers like massage therapists and other providers are now not allowed to go into some senior communities, which is just sort of adding more stress to the staff and feeding more isolation to the residents. Any thoughts on that?
Yeah, this whole story of the lockdowns in senior communities has been just terrible, and I think everybody understands why it was done. Especially in the spring when COVID was just so awful in long-term care facilities, something had to happen. But nobody understood the rules. They were different from place to place, drove everybody crazy. The fact that outside providers like massage therapists, OTs and PTs can't come in has been a sense of great frustration for everybody. The fact that families can't come in has been a source of great frustration. I noticed that just yesterday, I think Governor Hogan said that he is going to begin to open up long-term care facilities to some outside visitors. And I hope that's going to include people like massage therapists and OTs and PTs. But, we're just going to have to see how it goes. The vaccine, I think, is going to address a lot of this. I think it's going to make it possible for these places to open up. But until people are fully vaccinated, we're still going to be stuck in this just really awful situation.
Great. Okay, let's see. Trying to get through these questions here. Technology, is there legislation coming that can provide free or low-cost internet for seniors? Most major cable providers don't offer any significant discounts.
Yeah, this again is a sense of enormous frustration. So let me give you a good example. Again, I'll talk about Jewish Council for the Aging. So we were running 3 adult day programs, in-person adult day programs. We had to close them all last March. We have transformed into a virtual adult day program called KC at Home, Kensington Club at Home. It works really well if you've got broadband and if you have a device. And what do you do if you don't? I would love to see there's a lot of interest in Congress in funding broadband infrastructure, and it would be really good to see that include some provisions that are going to get that make it possible for older adults to access that technology. There are some cities that do it. Philadelphia, I think, is a city that does it. I think there are a few others that have public broadband. But there are too many places that don't. And I don't know any place around here that does, for example. And it's a shame. And as we're in a virtual world, it's a real lost opportunity. We will at JCA go back to in-person adult day, but we also hope that we can continue to do it virtually. But again, it's only going to work to its maximum if people have access, which they don't now.
All right. I'm trying to sort of scan these questions because we got a bunch of them, but I want to begin to sort of wrap things up. You've really given us a lot of time and a lot of good insights. Let's see. Medicare, Catherine says, Medicare is allowing myself and other behavioral health providers to provide mental health during through March 2020. How likely is Medicare going to extend this telemental health?
Hard to know. I have a sense, this is just a guess. I don't have any inside information on this one, but my guess is that telemed is here to stay. And whether it's for mental health or it's for any other medical care. I think that this became a kind of an experiment under great stress. But I think the sense is that this experiment has actually worked quite well. And I would not be surprised to see permanent funding for telemed of all kinds as a result of what we've learned from COVID. So I'd be fairly optimistic about that.
Great. And this I'm going to try to paraphrase Catherine Campbell's question. She, agrees that low-income housing tax credits would be a great solution, but she's saying we offer service coordination as a way of keeping older adults independent by connecting them with healthcare and home healthcare services. Do you see Medicare and the health insurance industry moving to support service coordination with the new administration?
So Medicare Advantage is going to do that for sure. It's already doing it. Will fee-for-service pay for service coordination? This has been something that care managers and other people have been trying to get forever. And Medicare has always been fee-for-service Medicare has always been extremely reluctant. I think now that managed care is doing it, I think there may be an effort to create some funding stream so that fee-for-service Medicare can do it. I think it's a great idea. The problem, I'm a broken record, the problem is it's going to add to the cost of Medicare and who's going to pay for it. It would be wonderful if there were evidence, if there was strong, academically sustainable evidence that doing this kind of case management reduced other Medicare costs. And the evidence is just not strong. And it's not because it doesn't work, it's because it hasn't been studied enough. So I think we're going to have to go through a period of research to get the evidence. It's true about all of the sort of supportive services that people get at home. We have good evidence that, for example, Meals on Wheels actually does work to do this. But all that other stuff, transportation, care, case management, all of that, we just don't know if it works because it hasn't been studied.
Great. Okay, I'm gonna kind of wrap up with a couple of questions. I know there's more there, but Howard's been very generous with his time and really speaks to what an engaging topic this is. I like this one from Mickey. What specific legislations are the most important ones for us to advocate in order to make improvements in the health of older adults of color? But I would say I'd love your thoughts on advocating for older adults of color, but what should we be advocating for older adults as a whole as well?
So what are the most doable? What are the low-hanging fruit that we can actually succeed on? So family leave, I think That's one that's going to work its way through Congress very quickly. It's really important that people make sure that older adults are top of mind and they don't get forgotten about as that family leave bill works its way through Congress. So I would absolutely say that's probably my top priority. The second one I think is one that's gotten less attention, but that's Older Americans Act funding. All of those ancillary services, the transportation, the information referral, the Meals on Wheels, all of that is funded through the Older Americans Act. That program has been essentially flat funded since before the Obama administration. Um, we need to make sure we get more money in that program because that's a very important way for people to be able to stay at home. And then the Medicaid funding. I think getting enough money in Medicaid, home and community-based services, so that those services are really work for people, I think is also really, really important.
Great. Well, man, this has been great. And my apologies if I didn't address some of your questions in the audience. We probably entertain more questions than we ever have in any of these pro-aging digital discussions. And Howard, thank you so much for your time and your insights and such stimulating conversation amongst our audience. I love seeing this.
Steve, it's a pleasure to do it. I'll send you a bill for the overtime, but this has been a lot of fun. Thank you.
Okay, great. And for everybody, we'll have this recording up shortly, and we'll make sure to send out an email to everybody. Thanks again, Howard.
Thank you.